So this is kind of a review of what I just taught you. Yeah. But you might want to have it in writing. So you'll see as you go through your nursing career, when this type of thing comes into play is with cardiac problems, right? If you have somebody with a high potassium, they may have an irregular heartbeat. If they have a low sodium, the same thing. Irregular heartbeat, irregularities in the heart. So you get people who are out in the hot sun all day long, and they are dehydrated, but they've also lost a lot of sodium. So they become confused, and sodium is part of it because of their nerve cells aren't polarizing and depolarizing properly because they don't have enough sodium on board. So salt's not a bad thing. Are you good with that one? So repolarization is that, like I just told you. So the neuron recovers immediately and then returns to a resting state. So easy to remember, repolarization and resting are virtually the same. So the depolarization that has occurred earlier in the picture that I drew is just passed on to the next section of the cell membrane as the impulse goes through. The impulse, referred to as action potential, can never go backwards. It can't go back up to the head of the neuron. It can only go forwards. So I guess it's easy in a way to remember that an impulse is an action potential, because an impulse is going to cause an action, and it's going to make something work. It's going to make your muscles contract. It's going to do something. Now, graded potential. The more intense the stimuli, the more ion channels are opened, allowing more of the ions to enter or exit the cell. So it increases the voltage. So what happens, remember we talked about the axion hillock, where you have stimulus coming into the axion hillock, but it's just not quite enough to make it start sending on that action potential. But if you have enough stimulus coming in, it will push it over the threshold, and you will get a stimulus or action potential will be generated. So that's what I mean by graded. It has to be graded up to a certain level before it sends on the next action. The only thing with this slide is that it doesn't diminish as it moves away from the source. It maintains, and the way it's helped to maintain is through the myelin sheath, right? It is your insulator. So it travels right through that synapse that we talked about earlier, that little piece of fluid that's between the two membranes. It passes right through without losing any strength at all. That's pretty important in the fact that if it lost its strength, then you wouldn't get your impulses up to your brain. They would just disappear. The synapse is this little, so we've got a little space between the membranes. The space between the membranes in here. Yeah, we kind of went through this before. It moves from one neuron to the presynaptic, then off to the postsynaptic. So it just jumps across from the pre to the postsynaptic membrane. And involves our neurotransmitters, the ones that I showed you earlier, that have come out of the vesicles. So then it slows, the impulse slows at the synaptic gap, but then it increases again at the axion hillock, so that never dissipates, it never disappears. It keeps going at the same level like the previous slide said. Structures that make up the synapse are the synaptic knob, which is this knob down here. The small sacs that are called vesicles of chemicals, which are the neurotransmitters. The synaptic cleft, which is the piece in here. And the plasma membrane. So they serve as receptors. I'll just let you guys read through that. Helicopter. Huh? Steven. Yeah. Yeah, he's finished that flying for the season, so we're looking for another job. Really? I came in and I had to take my jacket off, but now I feel cool now. It was warm when I first came in. We turned the temperature down. So this is just a diagram of what we've been talking about all along. Resting potential, grading potential, action potential, synaptic activity, and information processing. The all or none principle, we saw that in muscle tissue as well, right? It either contracts or it doesn't. It doesn't do a half of the contraction. So we see the same thing as this. That once it's generated, it remains the same no matter how large the stimulus. So the action potential, it either happens or it doesn't happen. We talked earlier about the axion hillock. If the action potential is strong enough, the axion hillock will pass it on. Now, important neurotransmitters. Acetylcholine is something you'll hear, and I think I mentioned it earlier with succinylcholine, which is the opposite, and they use it for anesthetizing people. Epinephrine, norepinephrine, you will find in your adrenal glands, and it is your fight-flight type of transmitter. Dopamine, you'll find in people who have Parkinson's, the lack of dopamine. Serotonin is your happy hormone. Serotonin helps you to feel happy, feel good about yourself. And GABA, you'll hear gabapentin, and I'm not sure if any of you have given medications. Gabapentin is very common. We used in diabetics who have peripheral neuropathies. Peripheral neuropathies are damage to the nerve cells usually in your feet, not usually anywhere else. but it does help with the pain of those. You'll see gabapentin is one thing. So we'll just go on to the neurotransmitters. And I believe it's on the paper I handed you, right? A list of neurotransmitters. Yep. Good. Okay. So these ones, all of these neurotransmitters, you're going to see in your pharmacology when you start talking about medication. So this is a good sort of a base for pharmacology. So acetylcholine is the primary neurotransmitter. You'll see that a lot as we're learning more about that particular transmitter. So it's released at the ends of the nerve fibers in the somatic and parasympathetic nervous systems. And it's also involved with transmission of nerve impulses to muscles. So when we give the opposite one, the acetylcholine, in a surgery, it actually paralyzes the muscles to the diaphragm, so they can't breathe. So that's why you put them on a respirator during surgery. So that would be the opposite of what the acetylcholine is doing. And it interferes at that synaptic. That's what the drug does. It interferes with that crossover. Norepinephrine is a hormone. It acts as a neurotransmitter, and it is located in the adrenal gland. Causes vasoconstriction and increases the heart rate. Now, the other time you'll see this is when people have asthma. A lot of your asthma medications are epinephrine based because what it does, it is the flight and fight response. And if you were running from something, you have to increase your heart rate. You have to dilate the blood vessels. You also have to increase your respiratory rate. And it opens up your bronchial tubes so that you can breathe better. And that's what we use the different types of asthma medications for, like Ventolin and Atrovent and those type of ones, is to increase the diameter of your bronchial tubes. So that's that's the type of medication you would see it. And it's in those puffers, usually, the Ventolin puffers. Lots of patients have those. Okay. Dopamine, we talked about that with Parkinson's disease and cocaine use. Excuse me. So the reduction of its concentration is associated with Parkinson's. And I'm not sure, I don't know how much involvement you've had with medications, but synapse is a common medication that we give people with Parkinson's that replaces the dopamine so that they can function normally. But with Parkinson's, oftentimes you'll see this shaking of the hands, and also a very stiff gated walk. And that type of thing, and it's obvious that it's a nerve problem, just because they can't walk properly, they have all these tremors. So it's quite apparent when they're getting dopamine, a lot of those symptoms disappear. And if they're cut off the dopamine, then all the symptoms come back very quickly. Serotonin. Tryptophan, that's the turkey one. That's what you get from turkey. So it actually makes you feel good. It's the feel good kind of neurotransmitter. So after your turkey dinner, then you get a load of serotonin and you feel really good. So it's found in the gastrointestinal tract. Serotonin is a local vasodilator and plays a role in brain and nerve function and the regulation of gastric secretion. Pharmacology, again, when you take that course, touches the it's similar to a CNS depression. Kind of slows things down, right? Makes you relax, makes you feel good. Remember I talked, gabapentin was used for pain in diabetics, for peripheral pain. So it has the property of stopping pain signals. And it's not sure how it is understood. You'll hear about it again as you go on in your nursing course with people who have phantom pain in limbs that are cut off. They use gabapentin quite a bit for that, to stop the discomfort. Neuromodulators. They're just the more chemicals, something more we learn, released by the synaptic nodes. They're similar function as neurotransmitters. So they're not reabsorbed and they're not broken down, and they circulate in the cerebral spinal fluid to regulate brain activity. So part similar function and this part circulating. The CSF are probably the most important part of that treatment. Characteristics of neuromodulators, the effects are long-term and slow to appear. You'll often find that with antidepressants. Right? They have to be, they're given for a long period of time before the person actually feels much better. But they do last a long time once the person has their blood level up. And you have to reduce them slowly. That's another thing. If you come off them, you don't just take yourself off them. You have to reduce them slowly so that you drop that blood level again. But the frustrating part with people who are on antidepressants is they take their pills and they expect to feel good right away. It does take a long time. It takes up to 2 weeks to a month before you get some effect from them. So if you have patients that are on antidepressants and they're telling you that they're not working, just encourage them to stay on them because it does take a long time for it to get going.
I wish that there was more like education surrounding like antidepressants. Because I was on Citralex, and then I was like, oh, I feel really good, no more anxiety. I want to take this anymore.
Yeah.
I myself completely
I know. And it's very difficult because people who have been on antidepressants, they feel well. And the immediate response to that is, I feel fine. I don't need these anymore. And they're forgetting that the reason they feel fine is because they are using the medication. So it's, as a nurse, encouraging people to stay on the medications because they do feel good is important. And you'll find with a lot of your long-term care patients, they are using antidepressants for them. And yeah, you encourage them that yes, they are going to feel better soon, but it does take a lot of time for it to go.
My daughter notices as soon as I
Yeah.
like she notices like things
Right.
things like the wrong for so long.
You
can tell
Yes. Yeah. And that's what the other thing too is reminding patients that are using antidepressants that there's nothing wrong with them. They're not sick. They're not crazy. They have an imbalance of obviously the neurotransmitters. So it's like me taking insulin. I mean, I have to take it to live. It's an imbalance of my system. I don't have any. I don't
produce any insulin. So it's the same with antidepressants. You're not producing those. Just like my insulin, if you don't take it, you're not going to feel that. So yeah, so it's an encouragement for people, because I know a lot of people are very resistant to taking antidepressants, and then they try to take themselves off as soon as they start to feel better.
Yeah.
It can be a bit of a problem.
Tried.
Mm-hmm. Yeah,
I
and it felt terrible. Yeah.
I thought the same thing as you thought.
Yeah, and you cut yourself off, that's it, and
Yeah.
no like tapering down,
Yeah.
less doses for over a couple of months. Yeah.
Okay, so neuropeptides are short-chain peptides found in the brain,
Such as endorphins. Now, endorphins are your happy. They're actually a morphine replacement in a way. They work the same way. So people who go out and jog get a high from jogging, and it's the endorphins being produced that give them that feeling of feeling good, right? When you injure yourself, when you've had a car accident or you really, injured yourself badly, you don't feel the pain for a while because your body is producing a bunch of endorphins to help you cope with that pain. So you may see people who have been in a motor vehicle accident wandering around and walking around at the site of a motor vehicle accident, though they are injured. It's because the body has produced a bunch of these endorphins and they're not feeling the pain. And that's quite dangerous because they could actually make the injuries a lot worse by moving around and walking around. And this part is kind of just informational. Don't worry about that.
opioids. The thing that everybody loves. All your opium drugs, right? Your morphine, opium itself, opioid drugs like hydromorph. There's quite a list of opioids. They work as binding in the receptors so that they prevent the pain signals from going down the axon, right? So in this synapse, they bind and prevent that, so they actually work in that way. The funny thing about pain, the person still is in pain. It's just that the messages aren't getting to their brain. So that's how they work. They just block the message. Addictions with opiates usually are psychological addictions. There can be some physical addiction as well, because when you withdraw opiates quickly, people sort of feel like they have a really bad flu. They don't feel very good. And that's where you run into all the problems with street use of opioids. Because people do become very reliant on them. But I explain to my patients who are worried about it, we're using morphine is our drug of choice for a lot of things that we do now. I explain to them that they won't become addicted because some people think, oh, I'm going to be addicted, don't give me morphine. It's a long-term thing as well. An addiction is a long-term thing. And usually there's some psychological aspects to addiction as well as physical. So using opiates for pain relief after an accident or, some kind of massive injury. We use them a lot in heart muscle if you are having a heart attack and that muscle is not getting enough blood. We use opiates to relieve the pain. Because once the pain is relieved, there's less damage to the muscle. So we have to try to relieve the pain right away. Okay, I think that's the end of that one. Yay! We'll see how
Yeah, but some really yellow things happen. Like for this example, there's 3 or 4 of them that are all things and children.
It's so nice outside today.
Yeah.
It's nice up there, and here we are. Like every day I move around, I'm just so lazy.
Oh. Sorry. Thanks. We're going to go on to the brain and spinal cord. So that, yeah, because that's in the right order. I haven't got my textbook with me. So we've done neuro. What happens after that is the brain and spinal cord. But I may have jumped. Yeah, so spinal cord, spinal. There's, I have a feeling that we will now be able to together. Yeah, this is a bit of a problem. Like I say, there's approximately four I'll run through. Okay, there's four different PowerPoints, and they're different ages. So I'm trying to make sure. Yeah, this looks like mine. Okay, I was thinking, yeah. Anyways, the adult spinal cord is about 18 inches long, and you don't really have to memorize that. It's just more information, and then half an inch wide. And it ends between L1 and L2. So your lumbar, L1 and L2 here, and that's where it ends. Now, did I hand out a picture of it? You guys, you wanna? I had one here, and I don't know if I photocopied it for you. Nope, it was actually a picture of the spinal cord. Oh, no. Okay, I probably didn't. I don't think I photocopied that one because it works so good. But I do have this with me. And it's actually, I believe this is a new textbook. So this one, isn't it? Yeah, that's a new textbook. And just that the spinal cord only goes down to lumbar 1 and 2, which is down here, which is about down here. So not that, it doesn't go all the way to the end of the vertebral column. Okay, So it does have the gross anatomy on here, on the slide. So it shows the amount of gray matter is the greatest in segments of the spinal cord, dedicated to sensory and motor control of the limbs. And the gray matter forms enlargements of the spinal cord around the cervical area and the lumbar area. Just means that it's a little bit thicker there. So down here you'll notice that it has the lumbar spines listed here. And then it has the cauda equina, which is, cauda equina is Latin for horse's tail. So what happens is the spinal cord itself actually ends, and then these are all just the nerves that come out. And they branch out of the spinal cord, and that's why they call it a horse's tail. It looks like a horse's tail. And it does give you your textbook number on there where this is. You want to put that in notes if you want to refer to it. So the spinal cord itself is held by thin threads of fibrous tissue that attach to the coccygeal ligament, and that's down at the bottom here. So it's attached down there. The spinal cord has segments, so they just go in the same as your vertebrae, in that same, because you have a thoracic. It has cervical 8, not 7. There's 7, and then there's 12 thoracic and 5 lumbar, 5 sacral, and it does have 1, not 4. So there's just a little extra. So there's 31 spinal cord segments. So there's 31 pairs of spinal nerves. And like I say, they're associated, they each have a vertebrae. So spinal nerves are numbered. That would be 31 names to remember. So it's good that they are just numbered. The nerves are named according to the vertebrae directly below it. Cervical, and all their spinal nerves are named after the vertebrae above it. Ah, yes. So that's why you end up with that odd number, because you have above and below. So you end up with 8 and 4 instead. But the 31 is the number that you want to know. So this is just a diagram showing where they come out, where the nerves come out. And it also gives you a description of the areas that they serve. You have to memorize all that? No. The spinal nerves are branched into 2 segments on each side of the spinal cord. The anterior root, which has the motor, here we go back to this again, afferent axons, and the dorsal root, the posterior, that has the afferent. I'm gonna get this wrong. The dorsal and ventral roots join to form one spinal nerve on each side of the spinal cord. I think you saw that in the picture that we had.
And I'm just showing the ventral roots, the dorsal root on this picture. And as you're seeing down here, this is a reflex hammer. And we'll be talking more about that later on, of which nerve that you're stimulating using reflex hammers. Yes?
If somebody's paralyzed, that means those nerves don't work, right? So when you
Yep.
get there,
Nothing would happen. Yeah, you're right. Right. Because those nerves are not transmitting any more signals anymore once there's been damage. There's all sorts of other things that go into partial damage and not complete damage, but for our purposes, we'll think that's totally damaged. Okay.
somebody who has implants in there, but it's still like
An implant in their knee?
yeah, like
Yes. Yeah. Because the knee joint itself has been removed, but all of the muscle tissue that surrounds the knee joint that causes movement still is active and has nerve innervation. But if the person had fallen and maybe broken, say the artificial knee joint, they wouldn't get any nervous messages to say it was broken. There's no nerves in there anymore. But they would get messages from the muscle tissue or the muscles that are trying to support it that it's broken. The ganglia, dorsal portion, root ganglia, contains the compost cell bodies, which are afferent nerves. So it's the major input center of all peripheral sensory neurons prior to entering the spinal cord. So that's the dorsal part. Again with the afferent and efferent. So just to add more confusion, again, there are all spinal nerves are mixed nerves, meaning they carry both afferent and efferent motor fibers. So they carry information in and they carry information out. When you break it down and you think of nerves as highways, you're going somewhere, then you're coming back. So that's the way you can think of it to remember. So again, they have a picture of the nerves, the spinal cord and the nerve roots, the ventral and dorsal root. So now we're talking about the meninges. The meninges are layers around the spinal cord and actually around the brain too. So they isolate the spinal cord from tissue, surrounding tissue. They protect the spinal cord, they supply blood, and they are continuous with the cranial meninges, meaning the lining that's around the brain comes around the brain and goes down and around the spinal cord as well. So it's one big, kind of like a balloon around. Meningitis, you've all heard of spinal meningitis, and that's what happens. The meninges themselves, that lining that's around the spinal cord and brain becomes inflamed and infected, and can be very serious. Haemophilus meningitis has been responsible for quite a few deaths in teenagers. For some reason, they succumb to it. There's viral meningitis where, people get viral meningitis and they have to recover by themselves. But there's bacterial meningitis as well, and those ones can be treated with antibiotics.
The fungal infections, meningitis, fungal infections are more common in the tropics, so we don't often hear them here. Okay. There's 3 layers, the Dura Mater, the arachnoid mater, and the pia mater. So Dura is on the outside, and arachnoid is in the middle, and the pia is the inner side, the side closest to the brain and closest to the spinal cord. And you have a patient who has a subarachnoid hemorrhage, which often you'll get in elderly people, will fall and they'll hit their heads, and the bleeding will start between those 2 layers. So you'll hear subarachnoid hemorrhages. Might be in their chart somewhere. But it's quite common in elderly people. Because as they age, the blood vessels are not as strong as they used to be, so they can break easier. So sometimes a very small blow to the head of an elderly person may bump their head on a cupboard or something like that, and they may end up with a subarachnoid hemorrhage. So if you have people who have fallen on your unit, and they may have been slightly confused before, and then a few hours afterwards of becoming more and more confused, you may think that they have had a hemorrhage of some sort between the layers of the meningeal layers. The Dura Mater is the outmost covering, and it's fibrous and it's tough. And it tapers to a dense cord, and that was the coccygeal ligament that's attached down here to keep the spinal cord in place. So the epidural space, and again you hear epidural hemorrhages and subdural hemorrhages, between the skull, vertebrae, and the Dura Mater, between the arachnoid mater and the Dura Mater. So that those 2 are just between the layers.
So that's where they read the epidural?
Epidural space, yes, you're right. That's where the medication goes, in between the spaces. It doesn't really ever come in contact with your spinal cord. It just is in that space. But you're right about the epidurals. And they're wonderful things.
So why are they so concerned when they give it to you?
They are concerned because it's not a very large space. So I don't know if you had an epidural for baby, for the type of baby. Okay. So you get the layers of membrane. And this picture, they're really far apart, but really they're very, very close together. Really, really close together. So they put a spinal needle in, and they have to get between those 2 layers. And when you realize that they're very, very close together, it's very hard to get between those 2 layers. You have to be very well trained and very confident. The problem is with those is going too far and getting it into the space around the spinal cord and doing nerve damage to the spinal cord. And that's the root. Spinal cord doesn't be your spinal cord. Say it's sitting right here. I'll make it really big because it would be really big. They may touch it and they may damage maybe some of the nerves that are coming out of it. It's hard to get between the vertebrae as well, because the vertebrae, like on our skeleton at the back, very close together. So to get between those bony prominences, it's difficult. So that's why they get you to bend forward or roll up in a little ball as best you can. And because it opens up the vertebrae column, the bones, so they get
very tricky skill, and that's why you find that the people that are doing it are they're specifically trained to do that.
Okay.
So you won't get just a general doctor doing it.
These are
amazing.
Yes.
Well, it was so funny because when Amanda had Mia, which is my first grandbaby, she was having a lot of pain, and she's just having a really bad delivery. And she's having a lot of pain, and the nurse who was with her was rather unkind. And she kept saying, "Oh, you're going to ask for an epidural. You're going to ask for an epidural." And she, "No, I'm going to have this baby naturally." So it went on and on. I think it just got worse and worse. Finally, she asked for the epidural. And she got really, you know how people get kind of strange when they're in labor? Yeah. She said to the nurse, because the nurse was always saying to her, "Well, she was named. She said, "I hate you," she says to the nurse. And then the doctor, just walked in behind. She was sitting up at the table and kind of getting ready to have the epidural. And she turns around and she says, "I love you." She really, it was so funny. Killing herself now. But yeah, epidurals are very effective. And there are the risks, like I say, of damage to the nerve damage. But there's also a lot greater risk with general anesthetic, right? So they're a good choice.
There's like if you have a trained, qualified
anesthetist doing it, then there shouldn't be there's very minimal risks. Okay, so we've kind of gone through that one.
The arachnoid mater, which is the middle one. So it's a subarachnoid space. It's just between the arachnoid and the tire. And it's the space through where the cerebrospinal fluid circulates. So the cerebrospinal fluid circulates around the spinal cord into the ventricles of the brain where it's produced, and it's got this kind of continuous circular motion. And I have a good picture of it somewhere here. I'll hand it around. Hang on a second. It's in my other books. I have so many books on the go, I kind of forget which one it's in. Okay, I will just draw it. So we have the brain here. Anyway, so in the center of the brain are what they call, there's fluid-filled ventricles. And that's where the cerebrospinal fluid is produced. It drains out, it drains down the spinal column, back up, around the front of the brain, and then back in again. So it does circulate in this fashion. And that's what they're talking about when they're saying circulate. Sometimes pictures are so much easier. Okay, the pia mater, which is the innermost one, which is closest to the brain and closest to the spinal cord, is a mesh of collagen and elastic fibers. And it's bound to the neural tissue below it and to the arachnoid mater above it. So it's got lots of blood vessels. I always think of that cartoon which has the truck, and the little truck is the cars. The cars animated and cars.
The guy, the little tow truck, he's called Mater. And I don't know how they got that name. Like every time I think of this, I think of him.
In Arizona, that was they made it just like Mater, like it was
I know. In Arizona.
Yeah.
I think you and I go to the same place this year. I went down. I went down.
Was there just
Yeah.
where they have the golf stand that goes back there with golf clubs and everything?
Oh, yeah.
And there's a pool in the
Same,
golf-
that's right. Yeah, I was there.
Where they got the big
That was-
place, like
yeah.
a big
Yeah.
one, right?
It was a great trip. The only thing I ended up having to drive the 2,000 kilometers or whatever it was that I drove, because Peter couldn't get a license down there. So I ended up driving. We didn't know that ahead of time. But anyway, sorry, I'm going to go back to work. So the distribution pattern of the spinal nerves relate to the regions they innervate. So that means just which regions did they serve. This is called a dermatome, and you do not have to memorize this on any degree. You just have to know that that's what dermatomes are. They are just the layers that the spinal nerves serve. So if you had somebody who was having bladder trouble, right? They couldn't void, or they were very incontinent, or they're having issues with that. It may be that it's affected from the lumbar. See, it says L1 here. So it could be from the L1 region that bladder isn't working properly. So that's where the dermatomes come into use, is just trying to figure out, maybe they have a spinal injury or they have some problems in the spine, and it's not that there's something wrong with the bladder, just the innervation might not be right. Okay. Nerve plexus. That's where they are interwoven, a complex area, so plexus is complex. They are of afferent and efferent, and sensory nerves are all in those nerve plexus. When I was saying about the dermatomes, don't bother learning how each one of them, because whenever somebody comes in to the emergency department with an issue, a neurological issue, we pull up the map. Like, we don't have them home memorized. We just get the picture out and try to figure out what might be wrong. Okay. Oops, oh my goodness. What happened? Okay, sorry, I just went all crazy. Oh. Held it too long. Very sensitive. So the four major nerve plexuses are the cervical, brachial, lumbar, and sacral. And you can kind of figure out where they are just by the name. So the cervical's got to be up in this area. The brachial plexus is over in the shoulder area. And the lumbar and sacral. So it's easy to figure out where they are. Okay. That's weird. Every time I touch that, it jumps. Okay. Yeah, I'll try again. Okay, so the cervical plexus, like I said, is in the cervical area. And it's in this. So it's got all these nerve roots in the cervical plexus. So the ventral branches, they're called rami, but that's something you may see again. So they are responsible for the nerve stimulus and nerve interactions in the neck and the thoracic cavity, so your lungs and this area here.
The major nerve that controls the diaphragm is the phrenic nerve. And the phrenic nerve, because it controls the diaphragm, you may hear about it again in your nursing courses. Because if you had any paralysis of the phrenic nerve, you wouldn't be able to breathe properly. Polio was one of the diseases in the past that caused loss of control of the diaphragm, and that's when they had to put the children into those iron lungs, which breathed for them. And it was interesting, this last acute care clinical in particular, one of our patients there was a victim of polio, and his legs were totally underdeveloped. And he told me that when he was 3 years old, he was in an iron lung for about a year. So it's very sad. So the brachial plexus is right here by the collarbone. So if you had somebody who had fractured their clavicle, they may damage the brachial plexus. So immediately you get loss of nerve innervation in that arm, numbness and tingling, and that's where that to the color of the sensation and movement and the numbness and tingling. So the brachial plexus includes the ventral branches of the spinal nerves C5 to T1. And it's responsible for shoulder, arm, and hand movement. Okay. The lumbar and sacral plexuses, you can see them located. So any damage to the lumbar or sacral plexus, you would have difficulty walking, of course. The lumbar plexus is the ventral branch of the spinal nerves T12 to L4, and the sacral is L4 to S4. Do you have to remember those numbers? No. just generally know that there's the four plexuses and what they are. Like they're a group of nerves altogether that innervate separate areas. Spinal reflexes, the nerve pathways are called spinal reflex arcs. So reflexes are a rapid motor response. They're excited by the spinal cord only. So the brain becomes aware of the response after its occurrence. So when we're talking about using a reflex hammer on your knee or on your elbow, or hitting that nerve, so really it's a response that happens immediately, and the brain really isn't involved in that response. It's more of a vocal type response.
When you get that,
It automatically jerks. Yeah.
That's not an automatic reaction?
Oh, the sensory automated?
Yeah.
No, it's not automated because your heart and the visceral muscle and your stomach and all that are automatic.
Yeah.
But that one isn't an automatic. It's more of it's more of a, it's not really, it's just a reflex to hitting it, right? So yeah, it's not the same as automatic. No, I understand. No, that's a good question. It is, because you would think, oh, it's an automatic reflex, but it's not. Okay. So like it's an involuntary physiological response to a stimuli.
That's what I was looking for, is involuntary.
Involuntary.
Okay. Today. So these are neural reflexes. And like I said, stabbing yourself with a pin. Step 2 is the activation of the sensory neuron. Step 3 is information at the central nervous system is processed. Step 4 is activation of a motor neuron. And step 5 is a response. And we've been talking about that all the way through. So innate reflexes, and like they say, they're formed before birth. And I know when your baby's born, that the baby already knows how to root, it knows how to suckle, it knows it has a grasp reflex, even though, but these are just ones that are formed before birth. And I don't know if you remember when you put your finger into your baby's hand when it was born, it would hold on tight. Yeah, so it's automatically holds on. Babinski's reflex is the sole of the foot. When you stroke the sole of the baby's foot, it usually, the toes go out. But that is a normal reflex for a baby, a newborn. They disappear as the baby grows and as the baby gets older. Some of these will disappear. The rooting and sucking reflexes, of course, they keep for a very long time. Mm-hmm. Yeah, and she does it like, yeah. And you look at her and I was telling her, she's like, oh, yeah. She might. I mean, the grasp reflex doesn't last that long. It was just randomly. She was not very often. Like,
yeah.
Like a video of her doing it, she's like,
well, it's just a reflex she's kept. That's all. That's nothing. There's nothing wrong with that. So the good part about those reflexes, the baby reflexes, is that it's a way of the doctor telling that a baby's neurological system is intact, like everything's fine with the baby. So when the doctor does this check right after the baby's born, he'll look at all these reflexes, right? Especially the Babinski's reflex, he'll check. Make sure baby's just normal. So somatic versus visceral. So somatic is skeletal muscles. Superficial reflexes of the mucous membranes of the skin. An example is plantar reflex. Plantar flexion reflex and the contraction of the quadriceps. Those are examples of somatic reflexes. But just remember, when you think of somatic, think of skeletal muscles, so the two S's kind of go together. So the visceral reflexes are internal organs or glands. So any of your internal organs like your pancreas, glandular, actually pancreas is glandular and it's both actually. That's two properties. It also produces enzymes for digestion. So a reflex is, a good example is the saliva in response to the smell of food, because you don't really think about producing saliva. It's just a reflex when you smell something good. Okay. You're getting hungry, aren't you? It's time for supper.
Some of the things that you don't even have control of.
Yeah.
You don't even know when it's like,
Right, it just happens. That's right.
Danielle didn't take a banana.
She forgot her banana.
The reason the banana is there. So what, do you know what
what bananas have in them as far as vitamins and minerals. Potassium, that's it. And when I gave up the bananas, the reason I gave that up was the potassium in the nerves when they depolarize and repolarize. There's potassium in there, so I gave up bananas for that reason. So you'd remember bananas, potassium, and that reaction of repolarization. Yeah. Also, I read an article that if you eat bananas before you do something like write an exam, that it actually helps you to concentrate. So there, when you write your exam, eat a banana before. See what happens. See what happens. Okay, processing. The site of information processing. Spinal reflexes occur in the spinal cord. Obviously, cranial reflexes occur in the brain. So cranial reflexes would be like going out into the sunlight and your pupils constrict. You don't really have any control over that, but it is a reflex. Blinking as well, it's a reflex, we never think about it. But it's not autonomic. It's a reflex, so autonomic and reflex are different. Plantar reflex, patellar, patellar reflex is the one where they hit that tendon and it jerks up. Reflexes are used by doctors, mostly with babies, they check to see the maturity of the baby's nervous system. But in adults, they can tell if your reflexes are slow or fast, and that gets back into the chemistry, right? Potassium and calcium ions can affect how fast and slow your reflexes are. So withdrawal reflexes, the body part moves away from the stimulus. So if you're have a patient that's semi-conscious or unconscious and you want to know what level they're at, you give them painful stimuli. And usually, it can be just as little as squeezing a fingertip or rubbing the sternum here. And the person, if they are, depending on the level of consciousness, will move away from it. They try to get away from the pain or pressure. So strength and extent of the response, it's because of the intensity and location. So if you had, trying to think, say a burn for, it depends how bad the burn is, what you're going to do, how fast you're going to respond to it, or how hot that fan is. A flexor reflex is, like I said, the hot pan, and you pull away from it as quickly as you can. Babinski's, what I was talking about with the baby. The baby, if you rub something up your finger or any sort of a hand, I've seen doctors just use the back of the hand gently, you can do it very hard. The toes will splay outward on an infant, and on an adult, they'll curl inward. And this Babinski's reflex will go away as the baby matures, and they can tell how mature the central nervous system is by that. We do it in adults because if they have had a brain injury of some sort, it may indicate some damage to the brain. If they don't have a Babinski's reflex. So we're going to the brain and cranial nerves. It's just about 4. you want to take another break now?
Yeah.
Or, and then, because we're here till 5:30, so that gives you. So, say 10 after, do you want to come back at 10 after? Okay. So we'll just leave this because it's a new section, so it works out well. Okay. Oh, we'll see what Peter's up to. Is it gone or coming out, did you say?
Yeah, it wasn't.
I'll never look at a banana in the same way now. Oh, nerve response. Okay.
Yeah, exactly.
Funny how nursing affects you.
Yeah. Yeah. One thing I love is cold pizza.
Oh, really?
Yeah. I can't really eat it, but it's cold and I
Oh, yeah, I can't eat it. Can't eat it. It wants to be hot cold.
Oh, really? That's just weird. So do you have a strong angry thoughts? Me too, with certain things, like, for me, it's onions. Like the smell for onions was like, but it's not so bad smelling them, but it's going in my mouth, and I know, or like people think, oh, you don't know, and even if they haven't told me, and I automatically taste it, and it's like instant, like right there and then. It's like, what are you doing? I don't need to do it.
It was like,
Yeah.
oh, it's working.
Yeah.
And hello, and how about the baby?
Yes.
I'm sorry. They're just looking at me like, and then when I got into this healthcare, it was like really hard not to do that.
Yeah. So you're in the healthcare program?
No, I graduated.
Oh, did you? So do you like it?
I didn't get a chance to work yet. I went to the farm and
The thing is so good. Like for me, I find for myself, like when you're younger, you're able to take it on a lot easier. But as you get older, it's hard to absorb information.
Yeah.
So that's the stage I'm at right now, where I'm really having a hard time struggling with LPN because it's so much information and it's trying to organize it all, like, and taking on. Like this, surprisingly, I'm totally enjoying it. But with the other courses, it's so much information.
Yeah.
I'm really pushing myself because I really want to, like, really know all the other nerves, but it's also like, for me, allowing myself that if I don't, then I'm okay with it because I love healthcare. Like, I love it. Like, there was, to me, it's like being a home care. I love the time that I spent with all of these people. There was nothing wrong with my job. It just happened to be that this program came up and I was offered it, paid everything. And I was like, okay. And I found out on Thursday. I quit my job the next day, like on a Friday. And then I was here, like the following week.
Oh, yeah.
So it's so fast.
Yeah.
Like I felt so guilty. Like, quit my job and, you know, all those things. And that's the thing, I'm like, whether I do it or not, at least I know I tried.
Yeah.
That's what I'm telling myself. It's okay if I don't. You know, it's okay, and it's even better if I do.
Yeah.
Because like the outcome is, for me, will be a better thing. That's the best part. That part is also, I'm used to working on my own. Oh, because I'm so used to being on my own.
Yeah.
And then the LPN, you're not on your own. Yeah. You're collaborating with the womb part, like the more I see of the womb.
Yeah.
I said with our gag reflex, right? You know. And I had like,
Yeah. I know.
I found with some of the DMs, I still have a hard time. Like in the blood in the urine.
Oh, yeah.
That's got it awful. So I can carry a regular urine.
Yeah.
And it's trying to control that because, you know, these are people.
Yeah.
And you try to think of their feelings
Yeah.
while you're doing it, because if you do that in front of them and they're, you know, they already have a low self-esteem because you're there taking care of them. It's like, and then when I get them really holding it back, and they're like, it's always already. I laugh when people laugh at myself with stupid things like that. And I think if you do laugh at yourself and do those things, oh yeah. Because even laughing at yourself, I just, that's one thing with the job, just walking.
Yeah, I like that. When I did a practice, I really enjoyed it.
Yeah. Like people, more of everybody in my class is doing facility work. But I think there's the pressures there and there's so much on your back. Oh, they work on your back. And the facility is a lot more than it would be because people in home care generally can do stuff for themselves. So you're helping address it. But there's a few people who had that were 2 people and stuff. For the most part, it was like amazing. I just loved it. Being able to go there and visit them and, you know, have a tea, you know, keep it there, or you can go and visit them and then do their care. And then you're actually allowed to sit there. Like you do have a limited time, but it's not as bad as in the facility where like 5-10 minutes to get the thing out of bed. You're not like so fast. Yeah. I don't look forward to that part of our practice. I'm going to go back and do it again.
Oh, really?
January we do facility. And then in April we do community. And then I think in November we go to a hospital.
Oh, yeah.
Or I kind of do like when I know everything goes the way I want it.
Oh, yeah.
That's where I want to be because I love kids like as only able to have fun. So for me, I just love being around them.
There are,
It's gonna be fun though. Because you're,
adrenaline.
I think it would be so busy. It would be like, you know, it's like if you didn't have downtime, so you can have it so busy. It's just crazy. And then you're like, and then people work out. And it's funny because I still have my mentality thinking more in our labs. I have the mentality of a home care worker. So that's my thought. So when I'm doing my documenting, that's what I'm thinking.
Yeah.
And then I'm like, oh yeah. Then I start to say, Brenda, you're not the healthcare worker. You're the nurse. You're the one directly. Because I write it down as per nurse requested, right? But I am the nurse. So it's like, yeah, it's like it's you doing it. And that's what you said, and we started laughing. I'm like, oh yeah. And she's like, because I couldn't get past that thought, right? It's like, oh yeah, I'm trained to be a nurse. But I only did home care for a year. 1 year and a couple months. And then I got into it. Yeah, I graduated last year. Where do you want to work? Facility or community?
I like community, but then I like both.
Yeah.
The facility is a lot of work.
It is a lot of that.
Yeah.
And that's what I found the most is where it's not. Community, I like, for me, I like it because I was at home.
Yeah.
Like if you had, or like if you go to something, you know, what service and
Yeah, my classmate was pregnant from the program. Every weekend. Only a week before our last. Really? Going on 2 weeks. She wanted to come back for to share a baby with she on the weekend. Yeah. No, you gotta recuperate. We're just taking a week off. It's like, oh yeah. But
you know, she probably didn't want to get left behind. Right?
Yeah.
Yeah, that's what I was doing. One of the classmates because we had some things at my job and she had to be off and I had to be off. So but it was weird because after everybody else was done, we had to come back and it was kind of lonely. I remember the last day and I think I had 2 more hours extra than our classmate. So and it was like 12 o'clock. She was leaving. I'm like, totally. She's like, hi. But I mean, I still got off an hour early because it was like 1 hour and it was a lunch break and I had to follow my those voluntary and she went off for lunch for an hour. So it's like, you might as well just work till 11 and then you can go to the dinner. And it's like, hey. But if we did that, you're there by yourself.
Yeah.
That wouldn't wait for the mention work, you know.
Yeah.
On the forums, I really want special. Yeah, I like that.
I like that one too.
That one was my favorite.
Yeah.
But it was hard to see nobody when I got there was walking. But the time I made left the facility, he was like in the like he went downhill so fast. I think it was last year.
She was talking fine and everything, and then a few days later she just went downhill. Like the day before she passed away, she was really clean with me. And then seeing all that and coming back, and then you're like, oh, maybe she
Emotionally too, right? Because you have that bond with certain ones and they need you, right? And that's the part I hated about this days that you don't have the time to sit there with me and you like treating for extra 10 minutes. And it was like, wow. And that was like when I did my medical, I had the same thing with one month and he didn't have to be told me that. And it was the same thing like he was because nobody listened to him. And he spoke our language and sitting there just listening to him and was acknowledging that he was still conscious. And he was like, that's what I did. And then it was the next day, he was like, still here. He's like, no, no, all I guys are crying because you know, having to do the debriefing, like, how was your day? Yeah, it was like, but I mean, it was a good thing because at least we got to experience that. Yeah, like have a better understanding of why you're going to run it when you're not in it.
I guess that was the hardest part of not
That's where I recognize you from. I see you at the nurse's residence in Littlewood. Stayed there, like it was a while ago.
We had a course over there quite a while ago. I'm thinking years ago, quite a while ago that we were there. But I've been at Coquihalla-Gillis with students from PCC and Kamloops. And
Did you ever stay at the nurse's residence?
no, I don't think I ever did. I mean, I stayed over there overnight, but not the nurse's residence. Because there was quite they used to have a lot of courses that we coordinated with Ashcroft and Lillooet, and they would come to our courses and we would go to theirs. It hasn't happened in the last few years, but yeah, we used to go over there quite frequently.
Not sure where.
All over the place. When the Lytton Hospital was still open, I used to go down there and do assessments with a friend of mine who did the long-term care assessments. I was down in Lytton. Merritt Hospital I've been in a few times. You know, Peggy Fraser, she works there in Merritt. I think probably with students. I had a student in Merritt actually, I did. I could have been over there to see her. So sometimes they. Yeah, well, you probably have, because like I said, I'm around a lot with students and stuff.
I know you
So the different, I know, I just have to put it together. That's right. Well, I taught at TCC for about 3 or 4 years, and that's in Kent. And then I worked in Ashcroft for 20. No, actually, my son's third. Okay, so about 20. Probably 32 years actually. Yeah, so I've worked in Ashcroft off and on for a long time. So then we do transfers and stuff, so you never know. I might have been on a transfer somewhere. Okay, so human brain, it ranges from 750 cc's to 2,100 cc's. Not to do those cc's things, but anyway, 98% of the body's neural tissue. And it weighs approximately 3 pounds. Some days when you've been thinking a lot, it probably weighs a lot more. Yeah, it's so heavy.
I believe that.
Yes, I do too. Oh, it doesn't like me very much. Come on. There. Try it. If I push it, hold it too long. Okay. There. So 6 major regions of the brain and function. There we go. So we've got a picture there on your desk, similar to this one here. Similar to this one. So the cerebrum, sometimes it's a little difficult. The cerebrum, cerebellum, they sound sort of the same. But the cerebrum is kind of the larger part. So it's got the frontal lobe, which is this area right here, this big white area here. The parietal lobe, the pinkish area. The temporal lobe on the side here where the temples are. And the occipital lobe. So there's those 4 areas of the cerebrum. The cerebellum, that back here, and we're going to be talking a lot more about each of these areas and telling you what functions are involved in. The dicephalon, which is inside, you can't see it in that picture. The right and left thalamus, hypothalamus, the midbrain, or mesencephalon, the pons, which is right here, connects the brain to the brain stem, and the medulla oblongata that also connects the spinal cord to the brain. Okay, those ones, but we're going to talk about all of them. So I don't push it too hard. So the cerebrum is the largest part of the brain. So that's that big white one in the front there. So that's the largest part of the brain. It controls our higher mental functions. So our speech, our thought processes, those type of things it controls. It's divided into the right and left cerebral hemisphere, separated by the corpus callosum.
Corpus callosum is just the fold. And I don't know if you can see pictures here. Corpus callosum is just that fold in the middle. And you're looking at the top of it. Separate them into two pieces. And the surface layer of gray matter, or neural cortex, has folds in it. They're called gyra. And the ridges are called, I can't say that. Oh, sulci, sorry, sulci. And the fissures are the deep grooves. So all those little grooves and things that you see in the brain, in your picture and in this one here, are what they're talking about in the surface layer of the gray matter. Now the reason they have folds and grooves is it increases the surface area. So if you have just a flat piece of paper, this is your surface area, if you fold it all up, you can get a lot more into a small space. So it just increases the surface area, therefore increases the ability of the brain to do more functions. Oh, this one, fissures? Sorry, is that right? Fissures are deep grooves. The cerebrum, each cerebral hemisphere receives sensory information from and sends motor commands to the opposite side of the body. Now this is really important when you get into patients who've had a stroke. So if they stroked on their left side, their right side will be affected. If they stroke on the right side, their left side will be affected. And it's just that it crosses over from one side to the other, and that's what happens. But it's important in the fact that if you have a cerebral vascular accident, you'll know which side it happened on by the side that's paralyzed. Yeah. Yeah. It's just the opposite of the paralyzed side. They have different functions. Either side has different functions. And the correspondence between specific functions, specific regions, is not precise. In other words, they don't really know. So your left hemisphere is the dominant hemisphere. It controls reading, writing, math, decision-making, language, and speech. So I am very much right brain dominant. Okay. I'm in the arts and creative side. I'm not so great at math. Speech and language. Language is a problem. I wasn't very good at taking French. So I'm not a left brain dominant person. But I'll let you write those down because those ones you'll probably see again. So again, if you had damage to the left brain, it would affect these problems. So if you had a patient who was having difficulty after an accident with their reading and writing, their speech and language, you would know that the left side was damaged. The right side is the cerebral hemisphere relates to senses, touch, smell, sight, taste, feeling,
recognition of face and voice inflections. They also say right side dominant or more, or like more in the artistic. Okay. The cerebellum, just to make sure you got the, it's not the cerebrum anymore, it's the cerebellum, is the second largest part of the brain. So that's cerebellum. But it's further back, the cerebellum. Or is it the flowery looking thing? Oh, that, yeah, that's a little flower. That's, oh yeah, I see what you mean. Yeah, it does look like a flower. I'm looking at this one, and it's just, on this one, it's just like a little brown lump. The brown lump at the back of your brain. Okay. So the second largest part, and it coordinates the voluntary muscles, coordination, and balance. This is really important too, because any damage to the cerebellum is going to make it difficult for you to walk, difficult for you to have, and you know, balance and coordination are going to be affected. Definitely we'll see this in people who've had problems with injuries, who've had damage to the cerebellum, and they may not be able to walk afterwards. There's two hemispheres, so there's two pieces, two sides of that, and it's covered with the cerebellar cortex. And Purkinje cell, so it receives information from the proprioceptors, and we saw that earlier, the proprioceptors. The dicephalon links the cerebrum with the brainstem. So it has three divisions: left thalamus, right thalamus, and the hypothalamus. And there's probably more information about that too. The thalamus and hypothalamus relays, the thalamus relays and processes sensory information. You'll hear a lot about the thalamus and the hypothalamus. The hypothalamus is hormone production, emotions, and autonomic functions. So if there was any damage to the thalamus at all, then the input and output of information would be processed as well. And when we get into hormones later on in this course, we'll refer back to the hypothalamus again. Really kind of interesting when you think about any damage to these areas would affect anything that you do or how you feel, your emotions. So it's
Like we're walking a very, very fine line, right? No, no, unless you had injured yourself or you had a friend who injured themselves or had a concussion and you know they're not thinking clearly and they're confused. So it makes you think about how kind of fragile human beings are.
Yeah.
The pituitary gland, remember we had a picture of it in our skeletal system where it sits. It has its own little cradle, the sella turcica, which is a bone that it sits in. Because it's such an important major controller of the endocrine system, the body protects it as best it can. That's why it has its very own little, like I say, a little cradle that it sits in the bony structure of the brain, or that lower plate of the skull. Because it's a major control center, it is connected to the hypothalamus because that's where a lot of your hormone regulation is going on. So you see the hypothalamus is the hormone production, but it's being controlled by the pituitary gland. It's telling it what to do. When we get into the endocrine system, we'll be talking a lot about the pituitary gland again. Good. The brain stem, it's the relay station, of course, as it comes out of the head, out of the right here is the brain stem as it's coming out. So the brain stem does go down into the spinal cord, and so it does have the vertebrae around part of it. And if a person has a head injury and the brain swells, then it pushes that down. It actually pushes the brain stem down into the bones of the spinal column. And that's where it is very, very dangerous because these are the areas that are responsible for your breathing and your heart rate. So it can be a fatal injury if the brain swells too much and starts pushing the brain down, pushing all these. So it includes the mesencephalon, which is the midbrain. It might be easier to remember midbrain than it is to remember that nice big word. The pons and the medulla oblongata. Those are the three areas that it includes. The mesencephalon, like I said, it's called the midbrain. Let's skip one. Nope. Sight, sound associated, and associated reflexes. So if you had a brain injury and it was swelling and pushing the brain stem down, and the doctor tried to do those reflexes on your arms then you would have, the reflexes would be affected. So he could tell how much damage is going on from a head injury by checking the reflexes. And it maintains consciousness. There's people with what they call sleep or narcolepsy, which they just kind of fall asleep like that. These areas are the ones that are affected by that. You actually go off to sleep without even thought.
So it's harder for older people to lose.
You know, I think more it's more activity related because most of us physically, like Jill's chasing her kids around, you know, busy person. You're a busy person. Yeah. And you get exercise, you're outside, you get fresh air. I think mostly that's what it is. It's the lack of activity. They're really not tired when they go to bed. And I know all the long-term care facilities that I've been in and worked in over the years, they put them to bed too early. So, I mean, I don't sleep for 12 hours. I sleep maybe 6 if I'm lucky. But yeah, so I kind of wonder if that's more to do with it than some kind of brain problem. Excuse me. So the pons connects the cerebellum to the brainstem, and it's the motor control center. Again, the brainstem and these areas are so important because without your motor control, inability to do walking or standing or anything, if there's any damage to these areas, you definitely have a lot of problems. The medulla oblongata connects the brain to the spinal cord, and this is the one that regulates the autonomic functions, your heart rate, blood pressure. And they call it the most primitive part of the brain. There have been babies born with anencephaly, which is the lack of the front part of the brain. They don't have it, but they do have the brain stem, and they can still live because they can still breathe and they can still digest food and everything, but they can't think. And there's, it's actually very sad. So as long as you would have this area functioning properly, you can still live. You have basic body function. So when I was talking about the brain swelling, if you've been in a car accident, you had head injury, or you're playing hockey where you smash your head against the sideboards or something like that, and you have a swelling in the brain, and it's bad enough that it starts to push that brainstem down, the heart rate's going to change, blood pressure's going to change. So you're going to see a change in that. Oops. Just jumped ahead. Sorry. So the ventricles, we talked about those a little bit earlier when we were talking about cerebral spinal fluid. So the ventricles are fluid-filled, kind of like fluid-filled kind of sacs, just like we describe it in the center of the brain. So they are responsible for the production of cerebral spinal fluid. And is that actually flashing? Somebody got this to flash. Well, that was pretty good. So it shows you the circulation, how it circulates around. I thought so. I had to do a double take. I thought maybe, I was having some brain damage myself. And I was like, okay. Okay. Talk about. Okay, they just want the connections. They didn't want that they produce any fluid. Okay. So how is the brain protected and supported? The meninges we talked about earlier, which are the linings, right? So they offer some protection, and of course, your skull, your cranium. And because the brain is such an important organ, it has probably the most protection in the whole body. And the cerebral spinal fluid works as a bit of a cushion and moisturizes that too. And the blood-brain barrier, we talked about that too earlier.